One of the important things that MMRCs do is try to map some of the opportunities that they are finding across, what are called contributing factor classes. And we identified at least 400 different contributing factor classes, but in the paper presented what were the five most common and most frequently and thematically identified example recommendations. And while we didn't quantify what proportion of those were across patient, clinician, and system level, we did present them across contributing factor classes because we found that that was most cross-cutting. So MMRCs recommended, across the patient and community level interventions, across education and when to seek care, ways to reduce the patient burden on seeking care. For example, routine postpartum phone check-ins. For example, ensuring that the high proportion of patients do receive postpartum care. For example, kind of reducing insurance churn so that access to care by insurance is less of a barrier. And then from a clinician level, there were recommendations across maintaining an awareness that patients may be seen across a variety of facilities so that the clinicians or their staff that might be triaging phone calls are aware of potential pregnancy complications and can help escalate care for patients when needed. So one of the things that we find across MMRCs is this idea to think across levels to reduce barriers to patients in terms of accessing care, but also just to improve on a community patient facility and provider level recognition and understanding that there is a need for referral pathways so that if you are a clinician in an urgent care that has a patient that was recently pregnant and might have signs of infection, but may not have the tools or expertise needed to care for that patient, there is a streamlined way to get that patient into the right care at the right time. A great question because while, as I mentioned earlier, the United States does have amongst the highest rate of maternal deaths across peer nations, they are still a relatively rare event, which means that the data on effectiveness to reduce maternal mortality are quite limited, and that there's even less empirical evidence regarding interventions that reduce racial and ethnic disparities. Um, Infection and sepsis seems easy because as clinicians, we understand that timely antibiotics and source control are key. But as I discussed previously in the obstetric patient, it's more complicated given this overlap in presentation. But I think that what MMRCs are teaching us is that maternal mortality results from a very complex web of factors that includes, as I've mentioned, quality of healthcare, racism, socioeconomic status, community level of resources, and all within the broader policy environment. And that is really dynamic. And so that interventions can't be siloed. If we want them to be full and meaningful, we have to think about them across levels. And so some of the examples you mentioned, such as the sepsis bundle, is a really great place to start. That was developed by the Alliance for Innovation on Maternal Health. It's been endorsed by leading women's health organizations like the American College for Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine. And, it really thinks about reducing maternal death from infection and from sepsis across levels that include improving recognition and a call to clinicians to kind of standardize their diagnostic criteria. There's not one, but every health system can use their own data and their own patient level information to develop a diagnostic criteria and make sure that clinicians adhere to that. They call for system readiness. So that means that within your health system, wherever a patient is seen, if there's a concern for sepsis, that there's a pathway and an escalation mechanism to make sure that patients are seen. But also that within your health system, that you are tracking and have reportable system learning so that you understand when there's failure to rescue, but also understanding where there are opportunities for prevention and global improvement. And so in that way, thinking less about one intervention as improving standardized diagnostic criteria, but a package of interventions that starts from improving readiness and recognition, but also using your own hospital and population level data to improve health and ultimately to prevent these complications in your patients.